So hi guys, welcome to this webinar on the management of osteoporosis. My name is Jack Jeyaston. I'm a physiotherapist here at St. Leonard's Physiotherapy. A lot of you would have met me if you're clients at the clinic, probably most likely in the ONERO classes that we run. We run ONERO here at the clinic for people with osteoporosis as an exercise and education program. I believe we might have some people on the webinar tonight, though, who aren't clients. So welcome to you guys as well. So a little bit more about me before we get started. Well, there's a picture of me when I had a lot more hair. That was probably taken sometime last year before I did the world's greatest shave back in Feb. It seems to be slowly growing back though. But I did a Bachelor of Exercise and Sports Science at the University of Sydney back in 2016. That was a 3-year degree. And that was then followed by a Master's of Physiotherapy for a further 2 years, also at the University of Sydney. And since then, I've been working as a physio in the private practice realm for about 8 years now. And those last 2 years have been at St. Leonard's Physiotherapy, which I've enjoyed a lot so far. At the clinic, we are pretty busy. We, of course, do see lots of one-on-one appointments, and that's just for not just your general physiotherapy, but sports physiotherapy as well. But we will see people across all lifespans, from kids, adults, into the elderly. But a big focus on what we do is also running lots of chronic disease classes. So we run ONERO for osteoporosis. That's what we're going to be focusing on tonight. That's probably our biggest class. But we also do run a GLAD program for people with knee and hip osteoarthritis. We run an exercise class called BTIT for people with diabetes. We run a program called group therapy. And that's, I guess, people with general conditions or just looking to get into an exercise routine, maintain their balance, their strength and overall function. We do have a strong pediatric focus as well. We have Holly and Liv as our pediatric physios who see one-on-one clients, and they also run some adolescents and kids classes. So yeah, we're kept pretty busy at St. Leonard's here. Personally, my areas of interest, I do like the sports sides of physiotherapy. I was lucky enough last year to work with the under-21s Sydney Roosters rugby league team. So I learned a lot from my time there. I do like treating injured runners as well. But I do like the general post-operative rehab, so not just your sporting rehab like ACL reconstructions, but even just the general person who goes for a total hip, total knee replacement or some kind of rotator cuff repair. I like rehabbing all of those people as they get back to their personal goals. And since doing a lot more work with the ONERO side of things, I have gotten into like an interest of like bone related injuries, like bone stress injuries. I guess that's kind of under runners more so, but yeah, I have an interest there too. Outside of the clinic, I am pretty active. You'll see me doing a bit of running, a bit of gym. My exercise goal for this year is an event called a High Rocks that I've signed up for in Sydney in July. High Rocks, I guess in summary, is it's a lot of running. You like a lot of running laps, and in between the laps, you do other workstations, other exercises, things like burpees, lunges, rowing on the ski erg machine. Does sound pretty crazy and challenging, but that's what I like to do to myself. I also enjoy the outdoors, so enjoy hiking and going to the beach and just being with friends and family. Okay, enough about me. Let's get into, I guess, the outline of how things are going to run tonight. So we're going to start with looking just at bone anatomy itself and its response to loading. I think it's important to just get that foundation understanding first of bone and how it responds to load. And then that's going to move us on to looking at the cause and the risk factors of osteoporosis. There's both modifiable but also non-modifiable risk factors for the condition. Then we'll look at diagnosis. A lot of people listening have probably been diagnosed with osteoporosis or osteopenia. So we'll have a look at how that's done, and we'll try and interpret what a typical report would be that you would get back from a scan. And then that's going to lead us into the different interventions for osteoporosis. So medications has been around for quite a long time. A lot of people are on medications prescribed by their GP or usually an endocrinologist. And they do have their place in the management of osteoporosis. A lot of people don't like taking them, but they definitely do have their benefits and have been shown to improve someone's bone density most of the time. But then we're going to look at other interventions. Firstly, touching on the loading effect on bones again, because understanding that, really goes in the exercise component, how we can use that loading principle of the ONERO program that we run here, improve bone density. We'll also look at some of the other current research that's still happening since the initial research study came out for ONERO. Okay, so let's start off with the anatomy of bone. So starting right at the basics. So I guess you can kind of classify bones into two different types. You've got cortical bone and your trabecular bone. You think of your cortical bone as quite a compact bone, so the structure is quite dense. It's quite solid. Its location within the bone is usually on the outer shell of all your bones. And for your long bones, so think of your thigh bones, your femurs, or your upper arm bone, your humerus. The long shaft. Those are typically made up of the cortical type bone. So this type of bone is quite rigid, it's quite stiff. Coming back to that compact meaning. This is so it can resist that kind of bending and torsion movements. We want that bone to be quite strong in the shaft there. Because it is quite dense, it does have a slow turnover rate. We'll get into this a little bit later, but bones naturally have like a turnover period. They do like replace old bone and with new bone. Because of this compact bone, the way it's so rigid, it does have a slower turnover rate compared to trabecular bone. And just throughout age, we know it does become more porous. So porous meaning, think of more like holy. Bones themselves have quite a dense structure, but within the bones there are small holes, so spacing within the bone. But this spacing does naturally increase with age. Then we got our spongy bone. So think of this as even more porous than your compact bone. Think of it kind of like a honeycomb network. So there's a bit more space within the bone. Just because it is classified as spongy, don't think that you can just, mold it into different shapes. It is still quite hard. You can't just simply mold it, but it just kind of looks like a hard sponge. Now, its location is more so found in like the smaller, shorter, square-like bones. So think of bones like your pelvis, your ribs, and even like the vertebrae of your spine. But they are also found, you'll see this picture on the right here. This is a femur. And up in the red there, that's your spongy bone. So in your long bones, your trabecular bone is usually found like right at the end of the bone here. It's kind of depicted as red because it does house the bone marrow. The bone marrow is quite important to produce red blood cells for the body. Now, because of this honeycomb-like network, it's lighter, um, more flexible, but again, take that with a pinch of salt. Again, you still can't bend it, but it can withstand higher strains. You can see there it restrains up to 30% compared to 2% in the cortical bone. The neck of femur there goes through quite a bit of stress because of the angle it is at to the hip. So the trabecular bone is put there so it can withstand that higher load. Because it is a bit more porous and a bit more lighter, it has a higher turnover rate, so the bone is replaced quicker. But this does mean it can, unfortunately, respond faster to metabolic changes and therapeutic agents in like a negative way. So it can actually have a more rapid loss in its density, especially after menopause, leading to that bone becoming more fragile. Just going to quickly um, check the chat. Anything's happening there? Not everything. Everything looks okay. Okay, so coming to now the forces on bones. So forces naturally occur through the body, not just through muscles and joints, but excuse me, also through the bones. So here you can see an unloaded bone, this cylinder shape here. Now the following pictures next to it show that cylinder being molded or contorted. But again, don't think that your bone can just do this, but just think of the principle that's applied with the direction of the forces. So tension would be if this cylinder is stretched from either end. In a real life example, think of if you're just hanging yourself from a monkey bar with your legs dangling. You have that force going from top to bottom, kind of pulling things apart. The opposite of tension is compression. So forces coming from either end of the bone. Think of having a heavy backpack on your back, kind of pushing you down. And then you've got bending forces, where two forces come from opposite directions, but from either side. Think of doing like a bicep curl movement, that hinge kind of action. That would put a bending force through your upper arm bone. Then you've got a shear force. So we've got two forces coming from opposite sides, but one from the top, one from the bottom. So that can provide that kind of sliding force between those two forces. I guess I think of like someone playing rugby and someone gets tackled from the top, but also another opponent comes from the bottom and tackles them from the other side on their legs. So they have that shear force coming from opposite directions, one from the top, one from the bottom. You've got a torsion force. So think of this as just twisting. So if you're just simply turning your trunk in standing, looking behind you, that would be that kind of force. And then you've got combined loading, which is a combination of all of those above. Okay, now we're going to get into osteoporosis itself. So the National Institute of Health, it defines osteoporosis as a skeletal disorder characterized by compromised bone strength, predisposing to an increased risk of fracture. So in other words, it's just reduced bone mass and mineral content. So here on the left is a picture of a normal bone, which has, some holes through it, so that porous kind of structure. But on the right, the bone of osteoporosis, it's a lot more porous, a lot more space in, to an abnormal amount. So it's lighter and it's less dense. So it's that reduced bone mass and mineral content. As I touched on before, the trabecular bone is a bit more porous than cortical bone, so it's at a greater risk of degrading quickly over time, and more common with osteoporosis. Over 1 million Australians have osteoporosis, and a further 6 million have osteopenia, which is kind of a red flag. If osteopenia is the level before osteoporosis. So it's really important to try and catch people in this stage, osteopenia, and get interventions happening there before they progress to osteoporosis. 2/3 of people over 50 have osteopenia. So it's quite common as we get older, and really shows that once you do hit 50, you should be getting the relevant scan, which we'll go through later. Get the relevant scan to see if you do have osteoporosis. The thing about osteoporosis is that it's a silent condition, so there's no pain associated with it, no pain, no stiffness, different to something like osteoarthritis of the joints. So a lot of people don't realize they have it until they get this scan. They might be quite shocked when they actually see they have osteoporosis. It does happen in women more than men, unfortunately, mostly due to the hormones and women going through menopause. And there's some alarming stats that I've put here at the bottom. The rehab costs for hip fractures here in Australia exceed almost $200 million each year, and 70% of those costs are for people over the age of 70. So unfortunately, there are lots of people over 70 who sustain hip fractures, and that usually leads to having a total hip replacement or having an internal fixation, like screws put in their hip. So it's a big burden on our health system and our hospitals. And the other alarming stat, which is quite scary, is that 25% of patients, so 1 in 4 patients, die within 1 year after having a hip fracture. These are people usually, over the age of 70 in like the elderly population. Unfortunately, usually if you're over 70s, some people would have by then some other comorbidities, some other health degeneration in other areas. And so a hip fracture can often be the start of that downward spiral where they just continue to decondition. It's hard for them to increase their mobility. And yeah, unfortunately, a lot of people die with 1 year. So definitely highlights the importance of getting a diagnosis on this early and getting that early intervention so people can be living longer and more healthier lives. Okay, so we know that osteoporosis is the loss of bone density, but how does this actually occur in the body? So coming back to that bone turnover role, which I was briefly talking about before. So bone turning over is quite normal. Old bone is replaced with new bone over time. The bones you have in your body right now probably weren't there 5 to 10 years ago, which is pretty interesting if you think about it. Usually it takes 5 to 10 years for every bone cell in your body to remodel. So this is quite a normal, part of the human body. The role of this is to maintain structural integrity, to repair micro damage from daily stress that we sustain. And it's also shown to help with regulating calcium levels in the blood. So there's two main cells that drive this bone turnover. You've got the osteoblasts, which think of them as the bone builders, so they form the new bone tissue. And you've got the osteoclasts, which are like the bone cleaners. So they're the ones that break down that older bone. So on the right here, I've tried to find a picture that depicts that without too much complexity. So at the top there, you've got resting bone. And you go down to the right, you've got this big osteoclast coming in, and it's resorbing some of that bone at the top there. That triggers a response from the osteoblasts to then come in, and they lay down that new bone where that old bone was taken away. So that new bone is mineralized. That's that picture on the left, until it forms pretty much the same area of bone that was there at the start, and that's just an ongoing cycle that happens throughout life. So osteoporosis occurs when there's an imbalance of this. So there's a loss of bone mineral content happening at a higher rate than it can be replaced. That's pretty much how osteoporosis occurs. Okay, so we know how it occurs, but what are the causes? What are the risk factors? What are all the different things that kind of disrupt this natural cycle? We want this cycle to be like a one-to-one, things breaking down at the same rate that they're built back up. But there are some things that kind of get in the way, and they unfortunately cause the breaking down to happen at a faster rate, or the building up to be at a slower rate. So we know that aging is something that we can't change. It's a non-modifiable factor. As people age, naturally bone cells just break down faster than they are replaced. Hormonal changes. So I mentioned it's a lot more common in women. So when there's a sharp drop in estrogen at menopause, that kind of hormonal change can disrupt the natural bone cycle. But even in males, it's been shown that low testosterone levels also, they can increase the risk of developing osteoporosis. Then we've got nutritional deficiencies. So we know that not having enough calcium and vitamin D, that can affect the capacity for the bone production, so that osteoblast to kick in. Having an inactive lifestyle. So if you don't do much weight bearing or strength training exercise, that can lead to weaker bones. Lifestyle habits. So we know that tobacco in like cigarettes and excessive alcohol, these kinds of chemicals, they can disrupt that bone building side of things, leading to a net loss of bone density. The use of medications, so things like corticosteroids, anti-epileptics, and even certain cancer treatments, they affect that cycle and can reduce bone mass. And then we've got a lot of health conditions, particularly inflammatory disorders, so rheumatoid arthritis, diabetes, hypothyroidism, and digestive issues, the things like Crohn's disease. That chronic inflammation in the body can also negatively disrupt that cycle and impair someone's bone density. And the last one, this is another non-modifiable risk factor, is just your genetics. We unfortunately know that if if your mother, your grandmother, your auntie, if they had osteoporosis, then it just increases your likelihood of having it. Okay, so now we're going to get into the diagnosis of osteoporosis. Um, it's done in two ways. The first way is not that common, but we'll go through it quickly, and that's having what's called a minimal trauma fracture. So that would be classified as someone having a fracture from an event that shouldn't really, cause a fracture. Sometimes someone might unfortunately have a fracture from just falling from a regular standing height, or they might be picking up a somewhat heavy box and get get a sharp back pain, which turns out to be a fracture in their spine. So they're kind of minimal events that cause a fracture when they shouldn't. So even if someone's bone density in this case is actually normal on like a scan, um, and they have one of these minimal trauma fractures, they can still be classified as having osteoporosis. So even if their scan is normal. The more common way though is people finding out by doing a DEXA scan. So that's going to measure the bone mineral density. A lot of you people would have had a DEXA scan listening tonight. And the main thing that comes out of that DEXA scan, the main measurement we get is something called a T-score. T-score, think of it as a standard deviation away from someone of the same sex, but someone who's healthy in their 20s. So it's a comparison of you to a younger person in their 20s of the same age. So we know that with aging, naturally your bones are going to be a little bit less dense than someone in their 20s. So we do expect you to be a little bit kind of down, but not too far down. So with these T-score values here, so if you're more than -1, you're considered normal. So somewhat away from a 20-year-old is okay, but you don't want to be too far away. So if you're above -1, that's normal. If you are between -2.5 and -1, you're osteopenia, so in that middle kind of zone. But if you're below -2.5, then you're in that osteoporosis zone. So that's what a T-score is. In the report itself, so there'll be lots of other things which we'll go through now. So as it says here, the T-score, we just know that the lower that T-score is, it's just going to have that exponential increase of you having a fracture. I'm going to now try and zoom into this document so we can look through those other parameters that are sometimes measured. So here's someone's blurred out DEXA scan report. So on the far left column here, you've got the different sites that they measured the bone density at. So they had 2 different levels in the lumbar spine and your low back that was measured. And then these other ones are the hip. This person actually also had a measurement in their right forearm, in their radius bone. So this is the bone mineral density in grams per centimeter squared. But that doesn't mean much because it all comes back to that comparison to someone in their 20s. So here's the T-score of this person. They are roughly in that -2 category. And so that puts them in that osteopenia zone. Then you've got the Z-score. This one isn't talked about as much, but it's just kind of another like further detail you can look at. The Z-score is your comparison to someone of the same sex but same age. So someone in the same like demographic of you. They say if your Z-score is less than -2, that's a bit of a red flag. It's quite low. This person here, they're actually not too bad for compared to people in their age group. And then another nice thing that you a report will usually tell you, especially if you've had a report at the same imaging facility on multiple occasions, is it will tell you what's changed from your baseline, so the very first one that you would have had done, and the change from your last one. So this person here has had at least 3 scans over the years, and you can see that they've just been gradually just on the decline since their baseline. So that's another good way to see changes over time. So if someone goes on medication for 12 months to see what that has done, or if someone starts the ONERO program here, hopefully we start seeing those percentages in the positive. Other things that are usually reported on, there's this thing called your FRAX score, F-R-A-X. And this is kind of like an online algorithm where a patient would plug in lots of different like personal factors, like histories of broken bones, family history. You would normally plug in your T scores as well. You can actually do this online as well yourself. There's like a Frax calculator online. So it's an algorithm that spits out after you insert all this data. It spits out your chances of developing a major osteoporotic fracture or developing a hip fracture in the next 10 years. And this algorithm says if this major osteoporotic fracture percentage risk is above 20%, or if your hip fracture percentage is above a 3% chance of getting one in the next 10 years, then that's a bit of a red flag. And you should be seeking intervention for your low bone density, low 20%, 3% for hip fracture. So they're doing okay in this department. And lastly, the other thing that is usually mentioned is someone's trabecular bone score. So remember the trabecular bone, that more spongy-like bone at the end of your femurs, in the neck of femurs, it goes through a higher turnover rate. This kind of measures what they call like the microarchitecture of the bone. So it's another way to look at in a bit more detail what the quality of your bone is like. In this case, this person's TBS, so their trabecular bone score of the lumbar spine is 1.21. That puts them in a partially degraded category. So kind of that, I guess, middle zone. If they were less than 1.2, which they almost are, they'd be kind of in that red flag zone. So it's important to note. I'll just zoom out again. All these different measurements that you can get, T-score, Z-score, TBS, and FRAX score, they're all good things to look at, but it's only the T-score at the end of the day that can diagnose you with osteoporosis. Even if your Z-score is okay, or even your TBS score is normal, it all comes down to what that T-score is. Okay, so hopefully that gives you an understanding on a report, how to interpret that. So now we're going to go into medications as an intervention for osteoporosis. So we've got two different types of medications. We've got your anti-resorptives. Think of these as medications that aim to slow down that osteoclast activity, so trying to stop the bones breaking down too much. Remember, we don't want to stop that breaking down process altogether, because it's a normal part of our function, but we want to just try and slow it down a little bit. So types of medications that fit this category, you've got your HRTs, so your hormone replacement therapies. You've got this group of drugs called biphosphonates. Things like Actonel and Fosamax. These are taken weekly or monthly as tablets. Aclasta is another common one that some people might have heard of or might be using themselves, and this is usually done as an infusion annually. And then the other common one in this category is a type of drug called a rank ligand inhibitor, and its brand name is Prolia, which a lot of people might be on, and that's usually an injection done every 6 months. Then you've got another class of drugs called anabolics, and these are drugs that, I guess, on the opposite side of that bone cycle, they help to support the osteoblast function, so they help to build bone a lot better. The most common one that I've put in tonight's presentation is Evenity, which again, a lot of you might be on or might have heard of from other people. It's pretty new compared to some of the other drugs on the list here. It's only been around for a few years now. And what's good about Evenity is that besides helping to improve osteoblast function, it also acts as an anti-resorptive. So it's like a two-in-one action. So it also helps to slow down the bone breaking down. And it's usually done as an injection monthly. So overall, it's been shown that medications have, a 5 to 15% bone mineral density improvement, which is pretty good, and even better, up to a 50% reduction in fracture risk. So, that can't be understated. They definitely have their role as an intervention for osteoporosis. But unfortunately, a lot of people don't like taking them for a number of reasons, and we're about to get onto that now. So there are some issues with medications. There's unfortunately a poor compliance with people taking medications. It's been shown that over 1 year that 50% of people aren't taking their medications as prescribed, and it's often due to the side effects that occurs. Unfortunately, there are a lot of non-responders to medications. Up to 40% of people won't see a change in their bone mineral density after a year between having DEXA scans. Unfortunately, it was found out recently, I think it was last year, the ABC did they kind of looked into what happens to people who suddenly stop taking Prolia, one of those medications. And unfortunately, people who went off Prolia suddenly, there were cases of people who were getting rapid bone loss, so kind of doing the opposite of what it's designed to do. But people who were getting fractures all of a sudden from simple things, so those minimal trauma-like fractures. And even there were cases of people getting osteonecrosis of the jaw. So osteonecrosis is when the bone in the jaw, actually the cells start dying, which can cause lots of complications, lots of pain and issues from there. So that really led to doctors, GPs having to really educate patients on the risk of stopping drugs like Prolia too quickly, having to wean them off better. It did unfortunately give drugs in general a bit of a bad name. And there are just general side effects with a lot of these drugs. So, for example, HRT has been shown to, have patients show bloating, headaches, nausea. I've got listed cancer there, but it's quite rare. So I don't want to scare people too much, but it has been shown at a very, very low risk of people getting cancer from HRTs. Fosamax and Actinol, which are those biphosphonates, people can get, excuse me, nausea, heartburn, esophagitis, which is inflammation of your esophagus here in your lungs, abdominal pain, a cluster, which is another one of those biphosphonates. People can get things like flu-like symptoms, fevers, and Evenity has been shown to have side effects. That kind of two-in-one drug. People have been shown to get joint and muscle pain, headaches, and also flu-like symptoms. Okay, just going to again just double check if there's any. No, no current questions. Hopefully everyone's going okay. We're going to go back to the presentation here. Okay, so looking at now the loading effects of bone tissue. So this is what we're going to start talking about. The natural ways to increase bone density, but and that's usually through exercise. But let's just strip it back a bit and actually talk about how bones can change over time. So bones do adapt in the body just like any other tissue. So it's a dynamic structure. Wolff's law tells us that bone is deposited in areas of high stress, and it's resorbed in areas of low stress. So in other words, use it or lose it, not just for muscles, but also for your bones as well. So examples, environments here where there's low stress. So like here, people in space, so astronauts. Um, people obviously in space aren't weight bearing. So over time, it's been shown that they reduce their bone mass. Same with people who are wheelchair bound, and especially through their legs. Without that weight bearing, they also lose their bone mass quite quickly. Then on the other end of the scale, you've got like environments of high stress. So everyone here knows Rafael Nadal, the tennis player, the left-hander. So it's been shown through studies that his left arm is a lot thicker than his right arm, not just in muscle, but his bone as well, just from years of that repetitive stress of him hitting those balls with that high speed. Similarly, in baseball pitchers, it's been shown that a pitcher's dominant arm, their throwing arm, is also a lot thicker in its bone compared to the other side. So this shows us that bones can change over time, especially if we apply that high level of stress to it. Unfortunately, though, you know, I guess well, let's say before 2015, a lot of studies that looked at interventions or exercise interventions for people with osteoporosis didn't really show that good results. Um, it was always thought that people with osteoporosis had to be careful with doing high intensity exercise. Um, it was thought that people's bones were fragile in this population group, or they had a high risk of fracture or injury. So when exercise trials were done for people with osteoporosis, typically the types of exercise were, they were quite low intensity. So think of, people maybe were prescribed light weights, but they were kept quite light. Walking, swimming, yoga, and these kind of non-weight bearing activities. And interventions like falls prevention to stop someone potentially falling and breaking their bone. So whilst these types of exercise are completely fine in their own right, if someone's goal is to improve their bone mineral density, unfortunately, it's not going to do too much. These modes of exercise are too low in intensity, and bones will not adapt. But what we've recently known to be is that all bones, they need high strain and high strain rates for them to positively increase their density. So higher strain meaning increase in resistance, increase in the weights over time, so lifting quite heavy, and higher strain rates kind of comes down to like impact loading. So like jumping on the spot. It's been shown that the types of exercise for bones, they need to be high intensity, but over a short period of time. That's superior compared to a low intensity over a long period of time. So something like walking will be classified as low intensity over a long period of time. Bones need a short, sharp duration, and the weights have to be quite heavy. So the weights themselves, when we say heavy, we really want to be choosing a weight where by the time we've done about 5 to 8 reps, that we're working pretty hard and it's not easy. You can't easily do another rep. So it's quite a small rep range, but it comes back to that short period of time. Bones don't need too much time to adapt in a given workout set. It needs to be heavy though, so you've got to choose a weight that you're going to fatigue within 5 to 8 reps. The good thing about this rep range as well is that this rep range is good also for getting muscles larger. Muscles also pull on the bones when you're doing an exercise, and that pulling on the bone, that force on the bone, like I was talking before, on the top right here, doing like a heavy bicep curl is going to provide that bending kind of force to the bone. So that muscle is going to pull on that bone from either end, so the joint can move through space. So if you're getting a good heavy weight, which is going to increase your bone mass, it's probably going to also help your muscle mass as well. In terms of impact, as I mentioned, it needs to be a high impact, and again over a short period of time. So an example might be jumping, but landing quite hard. Typically, people jump and they don't want to land too hard, but over time, if you expose the body to landing harder, the bone is going to adapt in a positive manner. So that's the key combination of high weights or high resistance over a short period of time, and with that heavy kind of impact. That's what bones need to improve their bone density. So I think that's a bit of a myth. People just assume that running increases their bone mineral density. I just wanted to talk about that a little bit more. You would think that that repetitive, striking of your foot on like a concrete surface over time would that kind of impact would be good for bones. But studies have been done and they've kind of shown that's not to be the case. That running is not really going to actually increase your bone mineral density. So just to depict this graph here, so on the bottom here, or these areas, so TB is total body, FN femoral neck, FGT femoral greater trochanter, then you've got your total femur and your spine. So these are measuring different areas of bone in the body. And then these columns, so the white column is a control group. These people did no running and no weight training. Then you've got this group in the light gray. These are people who ran, but they did no weight training. All they did was run. But then you had a group that did running, but they also engaged in resistance training. So they actually did weights. And you can see over time of them doing exercise, here on the left, this left side of the graph is showing someone's increase in bone mineral density. And you can see it's only the group that did both running and resistance training that really got us an increase spike in their bone mineral density. You can see the light gray group, they're actually closer to the group that didn't do any running at all, which really shows that running on its own does not do anything for your bones. You really have to add that weight training factor to it. And that's probably because although running, people would consider that to be high intensity, especially if you're going for a really, say, hard half-hour run, because it's over a long period of time. As we said before, we know bones, they only require a short period of time. So if you're doing something over a long period of time, it's actually probably not that intense for the bone itself. It might be intense in terms of your cardiovascular system, so working your heart and your lungs hard, good for your fitness. So it's intense in that way, but it's not intense for the bones. And when you're landing each time that you're running, you're probably in that more like spring-like mode. So you're trying to have a short contact time and really spring forward to the next steps. You're not really landing that hard either. So that's why running, I think, doesn't really show an improvement in bone density. Again, running is completely fine for other metrics, like as I said, for like your fitness, but in terms of bone density, without the weight training, it's not going to really do too much. Okay, now we're going to look at the trial that really kind of changed everything in terms of interventions. As I said before, trials before 2015 weren't really looking at heavy weights because they were worried of people getting injured. But the Lift More trial, which was done here in Queensland about 10 years ago, or you can see there, published in 2017, this was kind of the game changer that kind of flipped the script. So it was an 8-month RCT, randomized control trial. And that's pretty high quality research. RCTs are pretty high quality. They took a large bunch of postmenopausal women who all had a degree of osteopenia or osteoporosis. They put them into two groups, and one group did twice a week, 30-minute sessions. And within that session, they did high intensity resistance training, 85% 1RM, which in other words is pretty much training in that 5 to 8 rep range. So they start off with a very light weight that they could handle. And over time, over the 8 months, they were just gradually increasing that weight. They also did a high impact exercise, like jumping on the spot, landing quite hard. And the other key component was it was highly supervised by like a trained physio or exercise physiologist. So over the 8 months, this high intensity group, they showed a 4% improvement in their spine BMD and a 2% improvement in their femoral neck BMD. But what was more striking was they got a 27% increase in that femoral neck thickness. So if you recall that femoral neck, where that trabecular bone is housed, that goes through quite a lot of force up near the hip, and it's where a lot of fractures occur, where that trabecular bone sits. So 27% increase in that femoral neck is going to really decrease the likelihood of breaking your neck or femur. Besides the increase in bone density, these groups also got an improved functional test in like strength, mobility, balance, posture. People even got a little bit taller just from improved posture. And the other key result is that there was a very low amount of injury. Coming back to the highly supervised exercise protocol, and due to the gradual increase in loads over time. I mean, that's the key thing. If weights are increased at a gradual amount and there's good feedback from both patients and therapists, then there's always going to be a low amount of risk of injury. So, as I said, it was really kind of the game changer and changed our way of thinking of the best approach for people with low bone mineral density in postmenopausal women. But you can see on the bottom right here, a similar lift more trial was done for men and showed similar good results. So from that trial was formed ONERO. So the bone clinic formed ONERO after that lift more trial. ONERO means load in Latin. That's where the name comes from, to load. That's essentially what we're doing. We're starting up with a small weight and we're just loading it up, building it up over time. So physiotherapists and exercise physiologists can be accredited and trained to become licensees of the program. So that's what we do here at St. Leonard's Physio. We've become licensees to run ONERO. At our practice, actually, just on that, we started the program probably around 2020, 2021 during COVID times. Started off with maybe about half a dozen classes, and now we've built to over 60 classes a week. So it's a very popular program. It's just becoming more well known out there in the media through GPs, endocrinologists, because people are really seeing the benefits of how to naturally improve someone's bone mineral density, especially people who don't want to be taking medications. So we are always accepting new people into our ONERO program. People usually do a one-on-one assessment first with us, so we can just go through our medical history and make sure you're a good fit for the program, and we can get you started pretty quickly into a group. So what we've seen after running this program, and these are real world results that the Bone Clinic has posted. People who continue ONERO for years on end, they get up to a 20% increase in their bone mineral density and up to 18% increase in their hips. And this has led to, there's a response rate of 70 to 85%, which is a lot higher compared to medications. So a big tick there for exercise, and over a 90% reduction in in fracture risk from falls, which is huge, because at the end of the day, we're trying to reduce the fractures, reduce those people going to hospital, and unfortunately getting deteriorating health from there. So, even me myself, having run this for 2 years at the clinic since joining, I've seen most people get repeat DEXA scans on a yearly basis, and mostly, not just plateau out. They don't just stop the bones from getting lower in density, but they actually improve it as well, which we love to see, and of course, patients love to see. We're going to just quickly look at some other research trials that have happened recently. A lot of recent trials have been looking at comparison of doing ONERO, so doing the high resistance intensity alone, but combining it with medications. So this MedX RCT done in 2022, it was looking at the particular medication of biphosphonates and Prolia, which are the ones, if you recall, that suppress the osteoclast activity. And I've just put in the conclusion here at the bottom, which said that preliminary analysis suggested that medication intake may enhance effects of high-intensity exercise. However, a large trial, including novel exposure to medication, is needed to fully examine the effect. So in summary, it shows that there actually might be a small benefit to combining medication and ONERO, although more studies need to be done, because when it says here about a larger trial including novel exposure to medication is needed, in this trial, a lot of the people they recruited were already taking medications for a number of years, so there was probably a bit of bias involved. In hindsight, it would be good for a trial to pick people who have not started ONERO or have started medication, so kind of started from scratch, rather than picking people based off what they've already been doing. So that's kind of why there's probably a low quality study, but it still does show promise for potentially a combination of drugs and ONERO. The Rolex Duo study in 2024, we actually had some patients join our program doing the Rolex Duo study. It's also comparing someone's bone density response over 3 different interventions, particularly looking at, again, drugs combined with the high intensity exercise, so combined with ONERO. This particular study is looking at Evenity as the drug, so that bone building drug. So you've got 3 groups. One group's doing Evenity combined with the ONERO. One group is just doing Evenity with low intensity exercise. And then there's a placebo group who are just doing low intensity exercise. In this case, low intensity exercise is just simple body weight home exercises, which is not supervised. So it'll be interesting to see what they find from this result. From this study. It is due to be completed this year in September, so we'll wait in anticipation for that. Okay, so probably gone a little bit over time, sorry. But in summary, we know that bones need that heavy load and that hard impact over a long period of time to adapt. We know that exercise, this type of exercise can be safe, especially if supervised. I think that's the key. A lot of people like coming to us doing these gym programs because they don't feel confident going to a gym on their own, doing it unsupervised. Their technique's not being watched. They don't know when to go up in the weight. That's really the benefit of having a physio guide you in a program like this. We often say to our patients that it's best not to look at the bone mineral density in the short term. It does take a long time. And that LIFT-MOL trial was done over 8 months. So you're not going to get a massive change in your bones in the first few weeks, let alone the first few months. It does take time. So it's also important to look at the other benefits you get besides bone mineral density. You're going to get increased muscle strength, That's going to happen a lot quicker compared to the bones. You can get increased balance, and that's just going to lead to better function, better independence, better quality of life. So that kind of leads on to the next point here of ONERO is really a lifestyle change, not just a temporary intervention. People often ask us if they can just do the program for one term or just 1 year and then stop. But as we've seen, bones adapt to load. So they'll positively adapt over the 1 year of doing a neuro. But if you just stop doing it all of a sudden, and you're not keeping up that high intensity programming, and the bones can unfortunately start to go backwards again. So we do try and strive people to, do a program like this for as long as they can. After people like coming back because they like being in their group. It's good. It's a good social outing for people. People are there for the same goals to improve their bone mineral density, and people see that it works, so they just keep coming back. Um, and exercise is used as a adjunct to medication. Medication definitely has its place. It's not completely bad. I'm fine with people taking medication, especially if they get a good outcome from it. And as we've seen, there is potentially um, a positive effect of combining medication with exercise to see even better improvement in bone mineral density. So certainly medication has its place and shouldn't be completely ignored. The last thing I just want to touch on is just with pain and injuries in the class. So as we said, there is a low risk of injury, but they still do occur sometimes. There are some people coming into the program who have other conditions such as knee joint arthritis or like shoulder pain. These can sometimes limit their capacity to go up in the weight quickly, so they have to be kind of graded at a slower pace. Sometimes these people, because they struggle to get that heavier weight, they may not see as much of an improvement compared to someone else. But as best we can, we always try and modify the exercise so we're not pushing into that other area of pain, and we're just trying to load the bones up as heavy as we can. And hopefully, as physios, I think we do a pretty good job to make sure everyone's getting the most out of the program as they can. Okay, so that's the end of the